So a patient that is hyperglycemic, nausea and vomiting, headache, weakness, fatigue, these are the classic symptoms for someone that is hyperglycemic. So these patients need some insulin to bring down the BG, get the sugar, carbs into the cells. So diabetic ketoacidosis, basically this is what happens a lot with patients that are not compliant with type 1 diabetes. These are patients that are hyperglycemic, way above 300, but not everybody that has a BG above 300 is diabetic ketoacidotic. So you have to have other symptoms along with it. So if you have a patient that has this, don't panic. It doesn't mean they're in this. They just may run pretty high. But anyway, what happens is you don't have any insulin getting into the cells. You have really high BGs, and the body starts breaking down fat to get some nutrition for the cells. So when it breaks down fat, it's going to produce something called ketones. So that's a byproduct of fat metabolism. So that's an acid. Ketones is a form of acid, which means their pH would be dropping, so they become more acidic. So after a long period of time, what's happening is the fat's breaking down, protein's going to be broken down as well. They get a lot of ketones in the blood, which is going to cause diuresis. So these patients that go into this then, they have polyuria. That's because the ketones in the body. Polydipsia, they're very thirsty because they're peeing everything out. And then they're very hungry because for a while we haven't had any energy get into the cells. So these patients become very dehydrated. They get dry mucous membranes, become tachycardic because they have a low pH, hypotension, lots of nausea and vomiting when it gets bad enough. So they're thirsty, they're hungry, but all they do is vomit when they try to drink or eat anything. Fast breathing comes into play because their pH is going down. They have acetones on their breath. It's kind of a fruity smell. And their serum bicarb is less than 15 because the kidney is trying to use up all its bicarb and make a compensation, so they're using everything up. So these patients basically get admitted to the hospital, and they're in critical care until they get through this diabetic ketoacidosis stage. So myth or reality, you can adjust your diabetes drugs to cover whatever you eat. Is that true or false? So treatment for diabetic ketoacidosis, well, you need IV access because you're going to give them lots of fluid, normal saline because they are dehydrated. They're going to be on an insulin drip, so a slow amount of insulin. We're going to start getting the blood sugar down, get the insulin in the blood so it takes the sugar into the cells. So these patients, when they come in, they could have a BG in 5, 6, 700 when they first start. So they start off with half or normal saline. It's usually normal saline is the most common. So you need to watch your urine output because once they become less dehydrated, you want to get your urine output up to 30 to 60 an hour. And you just slowly basically giving them lots of fluid IVs, doing your BGs regularly, adjusting the IV drip of insulin. And pretty much when the BG then gets down to about 250, you change fluids and you put on normal saline with D5 together. Because now all the sugar is starting to go in the cells, you don't want this patient to bottom out, so we add D5 to the IV fluid so they don't bottom out. We're still on an IV drip, so that's still part of the component. And the bad thing you have to watch is you have to watch the potassium all the time because when they first go into diabetic ketoacidosis, because they're acidotic, you are going to have an inflated potassium level, so they will be hyperkalemic, not hyperkalemic enough that you would risk them going into cardiac arrest, Although if they never sought help, they probably would go into cardiac arrest. So you have to watch that because the insulin is going to take the potassium into the cells. So at some point, these patients will probably need potassium as well as a treatment option. There's two things out there called hyperosmolar hyperglycemic syndrome, HHS, and the old term for that was hyperglycemic hyperosmolar non-ketotic syndrome, also called HINKS. So you may see HINKS or HHS, but this is basically what happens when patients that are not type 1 diabetic, but they're type 2 diabetics, they don't go into ketoacidosis, but they go into this. So they're basically just making enough insulin to prevent them going into ketoacidosis, but they would still have a high BG, but just enough so they don't go into ketoacidosis. So myth or reality? Artificial sweeteners are dangerous for people with diabetes. True or false? So long-term, patients that are long-term hyperglycemic, if they're not compliant, the worse they are for years, the quicker these things are going to happen. So damages nerve cells. You have atherosclerosis is going to increase. You have thickening of your capillaries and arterioles, especially in your kidneys, eyes, and skin. So with all these three together, that's why patients have a diabetic neuropathy. That's why they have a high risk of stroke and heart attack, and they have problems with kidney disease and going blind. So all these problems then come about because of the high sugars, high BG. So retinopathy, cataracts, hypertension, coronary artery disease, the islet cells and pancreas quit working, peripheral vascular disease, also peripheral arterial disease, peripheral venous disease, all of them, peripheral neuropathy, erectile dysfunction, and they are at a higher risk for infection. So neuropathy, 60 to 70 diabetic patients have neuropathy. That's a large amount, a huge amount of the population of diabetics. So they have loss of sensation, pain, paresthesias. They say it's tingling, burning, itching in their toes, in their extremities, under their skin. Not much you can do about this, although there are medications out there that help, like Neurontin, gabapentin. Some of those meds patients say will help their neuropathies. So, myth or reality? You need to eat special diabetic meals if you are a diabetic. So, neuropathies, how to help those? Well, stop smoking. If they're smoking, obviously that's going to make things worse. They're not going to be able to feel when it's too hot, when it's too cold, if their feet are getting frostbite. They need to wear comfortable footwear. They're not going to feel anything if it's in their feet and they've got a little pebble in their foot. So these patients also have problems with claudication. You usually see loss of hair on their lower extremities. They get claudication. So how they screen patients for their neuropathy is what's called monofilament screening. It's a 10-gauge little needle. They rub this needle over parts of their body, like on their feet, and see if the patient can feel anything, and then they basically gauge the severity of your neuropathy. So issues for teaching.